Welcome to Medicine in Our Backyard. This is a series presented in conjunction with UC Irvine Health by the Newport Beach Public Library Foundation. My name is Adrienne Windsor, and I am a member of the Board of Directors of the foundation. We'd like to thank our generous sponsors, Mike and Polly Smith. They have been with this program since its inception. They were part of the first idea for it. It's enabled us to empower the community to have access to this amazing resource that we have at the University of California at Irvine, the campus right next door to us. So it truly is medicine in our backyard. Our Newport Beach Library Foundation is a membership organization. If you are a member, we are very pleased to have you. If your membership is up for renewal, we are counting on you. And if you aren't a member, we hope you will join. So we thank you for being with us today. Now, the presentations will conclude with a Q&A session. So we request that you hold all questions to the end. Please use the Q&A box for your questions rather than the chat. Also know that this event will be recorded and available to watch on the Library Foundation's YouTube channel. The topic today is HPV-related throat cancer, an emerging epidemic and public health crisis. And I am pleased to introduce our two speakers this afternoon, Dr. Alan Chen and Dr. Tjoson Tjoa. Dr. Chen is chair of the Department of Radiation Oncology at UCI School of Medicine. He is board certified in radiation oncology by the American Board of Radiology. Dr. Chen is globally distinguished for research in head and neck cancers. He has published over 150 peer-reviewed articles and is an active leader in the American Society for Radiation Oncology and NCI. Dr. Chen earned his medical degree from Yale University School of Medicine and completed an internship in internal medicine at Kaiser Permanente Medical Center. He completed residency training in radiation oncology at the University of California, San Francisco, and at the MD Anderson Cancer Center in Houston. Dr. Tjoa is an assistant clinical professor of UC Irvine Health and specializes in the surgical treatment of head and neck cancer, major reconstructive surgery, microvascular techniques, thyroid surgery, salivary gland surgery, and skull-based surgery. Dr. Tjoa received his medical degree from Virginia Commonwealth University School of Medicine in Richmond, Virginia. He completed an internship in general surgery and residency in head and neck surgery at UC Irvine School of Medicine. He completed his clinical fellowship in head and neck surgical oncology and microvascular reconstruction at the Massachusetts Eye and Ear Infirmary and Massachusetts General Hospital at Harvard Medical School, where he was a clinical instructor as well. These two gentlemen are well-traveled, they are well-educated, they are so experienced, and we are pleased to welcome these distinguished UCI professors of medicine in our backyard. Dr. Chen will begin.
Great. Let me share my screen. Okay, so thank you for that lovely introduction. It's an honor to be here to speak about HPV-related throat cancer or oropharyngeal cancer and present some of our ongoing work at UCI Health. So I have no disclosures or conflicts of interest to report. So today we're going to talk about we're going to review factors underlying the emerging epidemic of HPV-associated oropharynx cancer. We're going to talk about how HPV makes these cancers more sensitive to radiation, and to discuss how de-escalation, which is a key buzzword of treatment, is becoming an exciting option increasingly for our patients. So first, some good news. If you look at the statistics, the incidence of head and neck cancer in the US has actually declined across all racial groups over the last few decades, and it continues to do so, and actually stands at an all-time historic low. So really good news there. And this is almost entirely attributed to the decreased smoking rates in the US, which really mirror the declining incidence of head and neck cancer. This slide illustrates many of the landmark public health initiatives that have helped pave the way Think about it. When was the last time anybody saw a TV commercial advertising for cigarettes, or even sitting next to a passenger on an airplane who was smoking? It's hard to believe that these prohibitive laws were once considered controversial when they were first proposed, but nonetheless have led to some really advances in public health. So Southern California is proud to have some of the lowest smoking rates in the country. The current percentage of folks who smoke here in Orange County stands at about 11%. It's hard to imagine that just 40 or even 50 years ago, as many of the old timers know, that number stood closer to 50%. And I think as a native Californian, I can proudly say that California should really be commended for its leadership in the public health arena, leading to the lowest smoking rates in the United States. California, in fact, has really set the standard in terms of promoting healthy lifestyles. We were the first state to ban smoking in the workplace, in restaurants and bars, within 20 feet of public buildings and in outdoor dining areas. And that's really resulted in us having some of the lowest cancer rates in the country. In fact, the number of people nationally who call themselves never smokers stands at an all-time record high. Nearly 150 million people consider themselves never smokers. So we get to a paradox that's really puzzled researchers historically. If smoking is down, the number of never smokers is an all-time high, and head and neck cancer incidence as a whole is down. Why are we seeing such a dramatic explosion, an epidemic, so to speak, in the incidence of throat cancer or oropharynx cancer? This slide really illustrates the dramatic explosion since about late 1990s in the rate of diagnosis of oropharynx cancer. Well, the answer to this paradox lies within the evolving landscape of HPV infection and patterns of transmission. In the United States, HPV represents the most common sexually transmitted disease. Nearly all sexually active men and women acquire the virus at some point in their lives. Most of these infections are asymptomatic and resolve, but there are approximately 14 million new cases annually, and vaccination rates for HPV still remain quite low. But the oncogenic potential, that is the ability of HPV to cause cancer, has been well established for other sites. For the cervix, the vulva, the anal area, the penile cancer is attributed to HPV. And over the last couple of decades, we've realized that throat cancer is also caused by HPV. And the dramatic explosion that we've seen in the diagnosis is certainly due to the increase in prevalence of oral HPV infection. In fact, HPV is the most common sexually transmitted disease in the US, with nearly 80 million people in the US currently harboring the disease. Just to put that into context, coronavirus infections in the US currently stand about 11 million. And so considering that a substantial proportion of these folks with oral HPV will develop throat cancer, the implications with respect to diagnosis and treatment are quite immense. So the epidemic has even captured the attention of the lay media in recent times. NBC News a couple years ago ran a lengthy segment on what they termed a public health crisis, that is oral HPV infection. Of course, since then, we've been preoccupied with another public health crisis of epic proportions, namely the coronavirus, but that doesn't mean we should forget about HPV and the devastating consequences it can have on society. So just how prevalent is oral HPV infection? Well, there was an agency called the National Health and Nutrition Examination Survey, and they actually screened almost 10,000 men and women who were asymptomatic, just normal volunteers like you and I, who could have been shopping at the mall or running errands at the post office or waiting at the bus stop. And they asked these random people who were totally asymptomatic between the ages of 14 and 69 to basically spit in a cup, and the saliva was tested for HPV. And they found quite remarkably that the prevalence, that is the rate of any sort of positive oral HPV infection, was about 12% for men and 3% for women. So, that just shows you how common this virus is in society, even among folks who have no idea they're even harboring it. Indeed, many people don't even realize that throat cancer has now eclipsed cervical cancer, and that's the disease in which most people think of when HPV comes up. There's a test, the pap smear, that was designed to screen for cervical cancer. Well, throat cancer has really eclipsed cervical cancer as the most common HPV-related cancer. And over the last 25 years, there's been a nearly 300% increase in the number of newly diagnosed cases. And this isn't just confined to the United States. Trends in the developed world mirror what we've seen here at home. The red line on these graphs show the HPV positive oropharyngeal cancer, and the black lines show the HPV negative cancers. So even in a country like Japan, where the prevalence of HPV-related cancer in the throat was once near zero, we're seeing a dramatic spike in incidence rates, and that's being replicated all across developed countries throughout the world. So HPV is a DNA virus. It's a microscopic virus, and it infects the mucosa surface of anything it comes into contact with. Quite commonly, it's eliminated by the body's host immune system, but in other cases, the HPV can actually lead to a growth. It's currently unknown how HPV leads to cancer, and unknown why some folks recover completely from the virus while others develop cancer. And again, as I stated earlier, just about all of us, or anybody who's been sexually active, is exposed to the virus at some point in their lives. We just don't know, what percentage of those are who actually develops the cancer. So recognition that HPV causes throat cancer is fairly new. In fact, it's only been about 20 years. In fact, back when I was in medical school, actually in 2000, that's when a group of researchers from Johns Hopkins identified HPV in throat cancer specimens, and they proposed a theory which was totally novel at the time, that this virus is actually what's responsible for the cancer development, and that would ultimately change paradigms in how we approach this cancer. So who's getting HPV positive throat cancer? Well, it's now clear that there are age-related trends. In fact, the disease is almost entirely confined to men for some unknown reason, although there have been theories that have been proposed. And it's not just men in general, but it's fairly younger men. And I like to use young because, I actually fall in this group between age of 40 and 54, as well as middle-aged men between age 55 and 64. And those are the two categories in which we're seeing an explosion in the incidence of HPV throat cancer. So clearly, this disease is a sexually transmitted disease. In fact, studies looking at risk factors have shown a definite correlation between sexual activity and throat cancer. So basically, anybody who's been sexually active is at risk, with the risk actually increasing with the intensity activity. So this study was actually published in the New England Journal of Medicine more than 10 years ago, and they actually show that the more lifetime sex partners one has had, the more of a propensity one is to engage in quote unquote high risk or promiscuous activity, and the younger age at which you first have intercourse, those are all sort of those put you at higher risk for developing throat cancer. So the evidence is now clearly showing that this is a sexually transmitted disease. In fact, studies have now shown that HPV positive and HPV negative throat cancers are indeed different entities with respect to causative factors. In fact, two distinct sets of risk factor profiles emerge based almost entirely on lifestyle. If you look at HPV positive tumors in this top section here, really what's causing the HPV positive tumors are sexual activity, oral sex in particular. For patients with HPV negative cancers, it's really tobacco, alcohol, poor oral hygiene, and dentition that's driving the causation of HPV negative cancer. So two different sort of profiles emerge depending on whether you're HPV positive or HPV negative with differing risk factors. In fact, it's very clear now that we're in fact dealing with two entirely separate cancers depending on whether one is HPV positive or HPV negative. You can see that the HPV positive patients, as we talked about, tend to be younger and middle-aged. The risk factors are usually sexual activity as opposed to tobacco and alcohol. And it's heavily dominant in men, and not only men, but white Caucasian men. And what I mean by comorbidities is these men are usually pretty healthy. In fact, I published a research study a few years ago showing that the incidence of traditional comorbidities such as COPD or diabetes or heart disease, high cholesterol, those diseases are almost non-existent among the HPV positive population. whereas they're very common in the HPV negative population. And those of us in the clinic probably appreciate that the HPV positive patients tend to be more educated. They're oftentimes professional, engineers, our bankers, our financiers, and as we talked about, they live healthy lifestyles, and we're seeing an explosion in the incidence. In fact, for those of us on the front lines in the clinic, we're seeing two different classes of patients emerging based on whether someone is HPV positive or HPV negative. So this gentleman on the left here is our classic hard living, hard drinking, head and neck cancer patient that we used to commonly see and sort of attribute to this disease. And this is your HPV negative patient, whereas Michael Douglas, for better or for worse, has sort of become the poster child of HPV positive throat cancer. But someone who's professional, young, well-dressed, younger, who hasn't really smoked or consumed alcohol in abundance, that's your typical HPV positive patient. So some really interesting trends in terms of who's being diagnosed with this cancer. And as we all know, HPV testing is now standard because it's been so well established, not only as a causative factor, but it's also, there are some treatment implications regarding whether someone is HPV positive or negative. So this is routinely done on all cancer specimens at any hospital across the country. But one of the most exciting developments in recent years is our recognition that HPV positive tumors have a much better outcome compared to HPV negative tumors. The presence alone of the HPV marker conveys such a positive prognostic advantage that traditional factors that we use to really predict outcomes, such as tumor size or bulk, or even stage. A lot of patients will ask, well, what stage am I? Those aren't even really relevant once someone is HPV positive. In fact, a new staging system was recently proposed to account for HPV positivity. And that was the first time a biomarker has been incorporated into the staging system for head and neck cancer. And lab studies have now conclusively shown that both in test tubes as well as in animals and humans, HPV positive tumors, as you can see on the bottom curve here, they melt much more quickly and are more responsive to radiation. In fact, the term intrinsic radiosensitivity is often used by our researchers, and it's been well shown that HPV really improves the intrinsic radiosensitivity of these tumors. This is a really busy slide, and if there are any scientists out there, they'll appreciate it. But really what it's designed to show is that there are several mechanisms that have been proposed for why HPV makes these cancers more sensitive to radiation. So everything from it affects DNA repair, affects the proportion of cancer stem cells. It affects what we call cell cycle regulation. In other words, HPV forces many of these tumor cells into more sensitive phases of what we call the cell cycle. HPV can affect hypoxia, or the oxygenation of these tumors. So thinking that the more oxygenated the tumors are, the more responsive they are to radiation, because the radiation really depends on oxygen for it to work. And then lastly, I think most of our work is focused on how HPV somehow ramps up the immune system, ramps up the body's host immune system to make it a little bit more active in its fight against cancer. So this was a study I actually published about 10 years ago, where we actually measured and plotted the volume of tumors for patients undergoing radiation using weekly MRIs that we obtained during treatment. And so you can see that for patients that are HPV positive versus those that are HPV negative, there are actually two different patterns of shrinkage that emerge. You can see that the patients that are HPV positive, their tumors are pretty much gone by week 5 or so, whereas patients that are HPV negative, they require 7 weeks, or even sometimes even more than 7 weeks, for their tumor volumes to really shrink to a nadir, or to plateau out. Whereas those patients that were HPV positive plateaued out about week 5 or even week 4 or so, really suggesting, well, maybe we don't need these final 2 weeks of radiation. And this is a good example here. You can see a large tumor here on the tongue on day 1, but by day 15, for this HPV positive tumor, it's gone away, it's flattened out completely. Similarly, by day 30, there's no evidence whatsoever of the tumor. And so it's a very typical scenario that we see in the HPV positive setting, shown in this graph here, oftentimes at week 4, week 5, tumor's gone, it's vanished, suggesting, really confirming our theories that this is a very, very sensitive tumor. So really, given that HPV positive tumors respond so exquisitely well, really the $1 million question that a lot of us researchers have been trying to ask is, does a one-size-fits-all approach to radiation therapy really make sense? In other words, should we continue to treat HPV positive and HPV negative tumors the same if we have all this evidence showing that the HPV positive tumors, respond so much better to treatment? And so that's where the buzzword de-escalation really comes into play, because it implies that we can somehow back off of the gas pedal, so to speak, and really tailor or attenuate the treatment for those patients that are HPV positive, maintaining very high cure rates, while perhaps by backing off on the intensity of treatment, we can maximize or optimize quality of life to a much more robust extent. And so several ways of de-escalation of therapy have been proposed, lowering the radiation doses, maybe reducing or eliminating chemotherapy, decreasing the amount or the area that's being targeted with radiation, reducing or shortening the treatments. And ultimately, the goal of de-escalation is really improve the quality of life. And so I think by de-escalation, our goal is that, by decreasing the radiation dose, and that's where most of my research is focused on, we can really decrease dysphagia, which is swallowing dysfunction, dry mouth, which is xerostomia, mucositis, which is pain, sores on the mouth, gastrostomy, feeding tube dependence, nerve injuries of the neck, fibrosis of the scar tissue in the neck, or hoarseness of the voice. And so those of you who are familiar with head and neck radiation, that either have seen folks or have gone through it themselves, know that 7 weeks or 6 weeks of radiation can be fairly difficult in leading to a whole host of side effects. And the goal of de-escalation is to really preserve the cure rates while really decreasing side effects. And so this is some data that's been published from my group when I was at UCLA. We actually published the first trial actually looking at de-escalation, where we reduced the radiation dose 15 to 20%. And we showed that we were able to achieve really, really good outcomes with a 2-year overall survival of nearly 100% and a cure rate of about 92%. We enrolled about 50 patients on this trial. This was published a few years ago, but it was really the first one that showed that de-escalation, it can be done and is most likely here to stay. Prior to that, I published a trial at UC Davis looking at radiation therapy alone for these HPV positive tumors, where we just eliminated chemotherapy, and we showed that the 3-year cure rate was about 91%. And so there are larger trials now testing these concepts, just doing radiation alone without chemo. And I do think that considerably more momentum is being generated to this day. If you look at the UCLA trial, which was published a few years ago, using 15 to 20% reductions in radiation, if you look at quality of life, at 6 months after radiation, none of our patients had feeding tubes. None of them were on a liquid diet only. Only 4% were on narcotics. And the vast majority of patients reported eating as much food as they wanted, excellent or outstanding quality of life, enough or normal saliva. And so these numbers were somewhat unprecedented compared to patients who really undergo the traditional radiation, in that the de-escalation patients, their quality of life was so dramatically better. And if you look at weight loss, if you look at one as their weight prior to treatment, nearly all of our patients on this de-escalation trial at UCLA regained their weight within 3 months after treatment, which was almost unheard of. So very promising results. We actually looked at our patients that got the de-escalated radiation dose and compared them to patients who decided not to go on the trial and just wanted the more aggressive 7 weeks of radiation. And if you look at every one of these domains, whether it was pain, activity, swallowing, saliva, mood, quality of life, there was an improvement for those patients that got the de-escalated radiation. So not only did we maintain really good cure rates, but we showed definitively that the quality of life was improved for patients that underwent de-escalation. We did a follow-up study asking about treatment regret. And basically this slide shows that almost all the patients that enrolled on the trial believe that de-escalation was the right decision for me. So from an emotional, psychosocial standpoint, even though anytime you go on a trial, you're somewhat taking a risk. Every one of our patients essentially felt like de-escalation was the right decision. And so this slide just shows some of the other notable trials currently being conducted across the country, just to show you that de-escalation is a very, very hot topic. And so conclusions, HPV is now firmly established as a cause of throat cancer. As we showed, HPV positive and HPV negative cancers are clinically and biologically distinct. HPV is the strongest predictor or determinant of treatment outcome. And de-escalation is really exciting. It's already here and will further refine treatment in the future. And I stayed on time, and thank you very much. And now I'm going to hand it over to Dr. Tjoa.
Thank you, Dr. Chen. I'm going to pull my slides up here. Okay, hopefully you can see that. I'm Tjoson Tjoa, head and neck surgery here at UC Irvine. Dr. Chen just highlighted a lot of the reasons why HPV positive oropharyngeal cancer is a cancer that I really enjoy treating and really enjoy talking about. You know, typically, and I'll talk about the reasons why I went into head and neck cancer, but typically when you're talking to a cancer patient, the main question that people have is, am I going to survive? Am I going to make it? And there's a couple cancers out there. HPV oropharyngeal cancer is the one that I can think of that the conversation has really switched from, am I going to make it, to how can I best thrive after my treatment? We're not talking about survival anymore with this cancer. A lot of times we're talking about how to minimize side effects. And when we're shifting that conversation from survival to side effects, I think that's a good thing. So today I'm going to be talking a little bit about the surgical side. Dr. Chen and I overlap a little bit in our slides, but on the important points, I'm going to go ahead and go over those again because there's certain take-home lessons that I think are important to take home from this. This is a quote that I really like. The greatest obstacle to discovery is the illusion of knowledge, and this is a quote from a otolaryngologist, a head and neck surgeon at the University of Pittsburgh. But I think this highlights a lot of kind of what's happening right now with HPV positive oropharynx cancer or throat cancer. On the left, there is a picture of the residents here in our Department of Head and Neck Surgery at UC Irvine. I'm also the residency director running the surgical training program here, and it's really a joy to work with a great group of 12 residents that we have right now. So I'm going to start with, I was asked by the organizers to talk about why I went into head and neck cancer and reconstructive surgery. So I'll talk with just a couple slides on that. The main thing is, you know, form and function make up our identity. So how we look, the face we give to the world, how we eat, the foods we enjoy, the foods we share with other people, our ability to hear and smell and see, all of those things are critical to who we are as a person. So being able to help people with those things that are so critical to their identity is one of the things that really made me attracted to head and neck surgery. Secondly, the anatomy. As a surgeon, the dissections are very delicate. Structures inside the ear, inside the nose, the neck is full of nerves and blood vessels. I love the surgeries. I find it challenging, and I find it really great to be able to help people with something that's integral to who they are while constantly refining a physical skill. I find that really exciting. And finally, why head and neck cancer? It's relationships. Really, I went into medicine, started medical school, hoping that I could be in a field where I formed relationships that were lifelong with my patients, and head and neck cancer really presents that. So these are photos of me with various patients and various staff. Dr. Chen is actually in this one here from our anti-cancer challenge that UC Irvine puts on every year. But you know, head and neck cancer patients, they're your patients for life. I follow them for life, and they have side effects that they deal with for life, and I get to know them very well. I get to know their families, and that's something that I find really rewarding about head and neck cancer care. So some of this information here overlaps with the information that Dr. Chen explained, but like I said, I think it's the important points that are important to go over again. So what is head and neck cancer, and who does it affect? Well, head and neck cancer is the 5th most common malignancy in the United States. It's not breast cancer, it's not colon cancer or prostate cancer, but it's right up there with an annual incidence of 600,000 people worldwide and an estimated over 60,000 cases in the US last year. like Dr. Chen said, is predominantly male more than female. And traditionally, the survival has been pretty poor, 40 to 50%. If you think as a head and neck cancer surgeon that 1 out of every 2 patients that come into your office is going to die of their cancer, that's a pretty discouraging statistic. And traditionally, that has been correct. Multiple subsites are included in the term head and neck cancer, and here's a diagram showing all the different areas that cancers can pop up. What we're focusing on today is the oropharynx, and particularly on the left there, the risk factor of HPV, like Dr. Chen elucidated in his study. So traditionally, the risk factors are smoking and alcohol. So you hear with the red squares, alcohol consumption in the United States has stayed relatively constant over the last 50 or 60 years, whereas smoking, because of some of the things that Dr. Chen talked about, has gone down precipitously, and that's been a really good thing. And so we would expect that head and neck cancer would go down too, given that smoking and alcohol are the 2 biggest risk factors. If you think about the traditional head and neck cancer patient, Dr. Chen also went over this. I have a few examples of people who had head and neck cancer and also died of head and neck cancer, and that includes Sigmund Freud, Humphrey Bogart, Sammy Davis Jr., and most recently, Eddie Van Halen. And if you notice, I purposely chose these pictures. What they all have in common is they're all holding a cigarette up to their mouths. So this is the traditional head and neck cancer patient. 30 years ago in a head and neck cancer clinic, it was filled with 70 or 80-year-old men who had smoked and drank for a large percentage of their life. What we're seeing now is a totally different demographic, like Dr. Chen mentioned. And these are all the different subsites of head and neck cancer, and you see the incidence of most of them is either stable or going down, but this line that's rising rapidly is oropharyngeal cancer right there. And the reason that is because the HPV virus, like Dr. Chen said. So you notice this does affect a younger population also, like he said. So Michael Douglas has become the poster child for HPV positive head and neck cancer, but Michael Cooper, the former Los Angeles Lakers who played with them during the Showtime years, also had head and neck cancer, and Jim Kelly more recently, young, healthy, not a big smoker, not a big drinker, they also have succumbed to head and neck cancer, or at least they've been affected by it. But what you also notice about the 3 of these is they're all alive today. And again, that's what's exciting about head and neck cancer today, is that it is a treatable disease. So the particular area we're talking about is the oropharynx, and that is mainly the back of the tongue and the tonsils. That constitutes the oropharynx. But we've seen a 3-fold increase in this particular subsite of head and neck cancer, and with an estimated 18,000 new cases in the US last year and 85,000 new cases per year worldwide. Like Dr. Chen said, white men are most commonly affected, and it tends to affect the higher socioeconomic stratus versus the old smoker-drinker head and neck cancer, which was kind of the people who were kind of down on their luck. This tends to affect the higher educated Caucasian men, although it is increasing in men of all races. We now know it is due to the HPV virus, like Dr. Chen said. There are low-risk versions that cause the warts that are shown in the pictures that he showed, but there's the high-risk versions that we're most concerned about, HPV 16 and 18. And HPV 16 in particular causes 95% of the throat cancers that are caused by HPV. HPV is the most common sexually transmitted infection in the United States, so virtually everyone gets it at some point in their life. What I tell patients is it's not something you got yesterday or the day before, even last year, that's caused your cancer. Usually the latency period between the time you have a throat infection from HPV, whether you feel symptoms from it or not, the time that in between the time you have the infection and the time you generate a cancer can be between 10 and 30 years or even longer. And why certain people generate the cancer who had the infection, whereas most people don't generate the cancer, we don't know. But there's some bad luck to it, there's some genetics to it, but because you have the cancer today doesn't mean you're infectious with HPV, it doesn't mean you have a sexually transmitted infection today, it just means at some point in your lifetime you were affected by this very common sexually transmitted infection. Dr. Chen showed the same graph. We used to associate HPV with cervical cancer, and we still do, which is why vaccinations are recommended for both boys and girls. But recently, oropharyngeal cancer has surpassed cervical cancer as the most common cancer caused by the HPV virus. With cervical cancer, we know there's a mechanism. We know there's precancer lesions that we can screen for, and that's why Pap smears are performed. It's taking a sample of the lining of the cervix to see if any of these precancer lesions are developing before they turn into cancer. Unfortunately, and what's different with cancer of the oral pharynx or throat cancer is that even though it's caused by HPV, there aren't precursor lesions that we know of. There's no swab you can do of the throat that shows you have precancer. Unfortunately, you don't know that you have HPV cancer risk until you have HPV cancer. So how does it present? How do you know if you have oropharyngeal cancer? The most common presentation that we see in our clinic is a neck mass. And neck masses are so common. Just because you have a neck mass doesn't mean you have cancer. And in fact, cancer is low in the causes of neck masses. So there can be cysts that you've had since childhood. There can be vascular malformations. There can be benign tumors. There can be infections. All of those can cause neck masses. And so most people end up going to their primary care doctor with a neck mass. They get treated with antibiotics. Sometimes they get the mass drained. And it's a mass that doesn't go away after 2 or 3 months. And in fact, sometimes grows over those 2 to 3 months. Those are the patients that end up seeing an ENT and ultimately getting referred to a head and neck cancer clinic. Sometimes it can present with a lump in the throat, since they are throat cancers, difficulty swallowing, ear pain, weight loss, and rarely patients can present with either changes in their voice or problems breathing, but usually it's pretty advanced by the time either of those occur. So what do you do when you have a neck mass? You want someone to examine you and try and get a sense of, is the mass concerning or not? And oftentimes it's not concerning at first because it's so low on even physicians' list of possibilities of causes of neck masses. But ultimately it may need referral to a specialist. And one of the reasons why specialists are needed in working up these neck masses is because it's a hard area to examine. The neck mass you can easily feel, but looking at the back of the tongue and looking at the tonsils can actually be pretty difficult. If you look here at the side view, the areas where cancers occur are here. Hopefully you can see my cursor, but here on the back of the tongue and here in the tonsil. And that's kind of around this corner that we're trying to look at. And so over time, people have developed different methods to look at that area. We still do this here in the head and neck surgery clinic, where we use reflected light off of a mirror that we use over our eye that then shines in the back of the throat. And we hold a second mirror that looks down the throat. And so what we're able to see, if you see on this picture on the right, is the back of the tongue and that tonsil area, which is a really tough exam for most practitioners to do. And so it really takes going to a skilled head and neck surgeon who is used to doing that exam to be able to see that. Alternatively, over the past 20 years, flexible laryngoscopy, which is this examination going on the left, allows us to look through a camera that goes into the nose and turns the corner to get down around the back of the throat. And that allows us to look at the back of the tongue and tonsils as well. And bimanual palpation is another sensitive way we have to detect these types of cancers. But all of this requires having some level of suspicion that there may be a cancer present there to begin with. So it's important, if you have a neck mass that's been there for more than 2 or 3 months and it's not been successfully treated with antibiotics, to not just think it's infection. Dr. Chen showed similar slides. Once you find a neck mass, or once you find a lump on the back of your tongue or in your tonsils, a biopsy is the next step, and this shows what the cancer looks like under a microscope with a special stain for a marker of the HPV virus on the right. And then ultimately, CT scans and PET scans can help us. CT scans are really detailed anatomic scans that can look deeper than the surface, and PET scans are scans that look for activity that we use to answer the question, has the cancer spread anywhere else in the body? Ultimately, if you're diagnosed with HPV positive oropharyngeal cancer, what is the treatment and what's the prognosis? I think you guys already have the answer to what the prognosis is. It can be good. And now the treatment is really the question that is the hot topic today among mostly radiation oncologists and head and neck surgeons. A lot of people associate chemotherapy as a treatment for cancer. Surprisingly, with these types of cancers in the head and neck, chemotherapy is not a curative treatment. Sometimes chemotherapy is used, but it's not used alone to cure cancer. It's really a cancer that's treated either with radiation or with surgery, oftentimes with both. The take-home point is that HPV with these cancers is a marker of better survival, and Dr. Chen showed a lot of data on that. This was kind of the first prospective study that looked at a large group of patients that had stage 3 and 4 cancer staged on a 1 through 4 scale. 3 and 4 are considered advanced stage. This study looked at 721 patients with stage 3 and 4 head and neck cancer and followed them for 4 years on average. It was published in the New England Journal of Medicine. It actually was looking at different radiation methods to treat the cancer, but what they ended up finding as their most significant finding was that patients with HPV positive cancers, that is, patients that had cancers that were caused by this virus, had an 82% survival after 3 years, whereas those who did not have cancers caused by this virus had a 57% survival. And so even after controlling for things like smoking and comorbidities, HPV status alone conferred improved survival on patients with throat cancer. So with that, the American Joint Committee on Cancer Staging changed the staging for specifically HPV positive throat cancers. And like Dr. Chen said, that's the first time that a biomarker has ever been used for cancer staging. So what I want to highlight here is in red, if it's HPV negative, we have different ways of staging the tumor. Basically, we see how big the tumor is and how much it has spread. And with those two things, how big it is here in the T category and how much it's spread in the N category. That's how we stage tumors on a scale of 1 through 4. And you see if your cancer is HPV negative, meaning not related to the virus, there are many ways to get to stage 4 cancer. If it's HPV positive, meaning it's related to the virus, there's only one way to get to stage 4 cancer, and that's if it spreads elsewhere in your body, not in your head and neck. And so that's a pretty rare situation, and what this highlights is that staging is related to prognosis, and it's really hard to have a really poor prognosis with HPV positive oropharyngeal cancers. And so that's really encouraging. So how does that affect us as a surgeon? So historically, in order to get to the back of the tongue and the tonsils to do a cancer surgery, we've had to do some pretty crazy things, including splitting the lip, sometimes splitting the jaw, sometimes splitting the tongue to try and get straight back there. These things required a breathing tube in the neck. They required reconstruction to kind of cover things back up after taking out the tumor. There was a high risk of saliva leaking into the neck after surgery, and they were highly morbid. Those surgeries were mostly done before the 90s and the year 2000. Because those surgeries were so morbid, there were a number of studies that looked at radiation and chemotherapy together to treat head and neck cancers. And what they found was that radiation and chemotherapy together can treat head and neck cancers as well as surgery could. And some would say with fewer side effects, without going through a jaw split or a lip split or a tongue split. And so in the 90s and the early 2000s, the pendulum swung away from surgery and towards chemotherapy and radiation, radiation being the primary mode there that's treating these head and neck cancers. But as Dr. Chen mentioned, those are not without side effects themselves. And so now we have, and this is the big point, now we have a cancer that's very treatable, and it's happening in younger and younger, healthier people. The treatment that we had previously for this cancer is really morbid. It's either a big surgery that requires a feeding tube and a breathing tube, or it's radiation and chemotherapy that comes with a lifetime of side effects. Since the cancer is so curable, are there ways that we can decrease the side effects in patients? And Dr. Chen mentioned several ways that he's looking, and radiation oncologists are looking into decreasing radiation dose to decrease side effects over time. As surgeons, what's been really amazing is that a technology has been developed separately from the HPV cancer that really allows us to treat the HPV cancer. And so there's kind of been an evolution of both surgical technique and disease understanding over the last 15 years because of these two things. And so that surgical technique uses a robot. The robot's used in a lot of surgeries. It was really developed in the OBGYN world and the urology world. But the head and neck surgeons have kind of adapted this to get back there and access the back of the tongue and the tonsils without having to split the jaw and open and split the tongue. And so this is a setup for a transoral robotic surgery in the operating room. Surgical times are much less, and surgical morbidity, more importantly, is really low. So large surgical studies looking at robotic surgery for base of tongue and tonsil cancers show a less than 4% incidence of complications. All of those things that made us shy away from surgery in the first place, like a tracheostomy tube and a G-tube and big incisions on the mouth and face, all of those things are not needed with robotic surgery. Over 90% of patients resume eating within 4 days of their surgery. Complications tend to occur less frequently at high volume centers like academic medical centers. And ultimately, this surgery may save patients from needing chemotherapy, which can add toxicity to the radiation treatment. And so like Dr. Chen said, the big buzzword in radiation oncology and surgery these days is de-escalation. And all of this is looking at that question, since these cancers are so treatable, how can we de-escalate treatment? How can we avoid these long-term side effects? I just want to touch on a few more things, and the main thing is vaccination. So HPV-associated oropharynx cancer, it's unique in that it's a cancer caused by an infectious disease. So it's a sexually transmitted disease that 10 to 30 years later causes a cancer. There's an American kind of Nobel Prize called the Lasker-DeBakey Research Award, which was given in 2017 to 2 scientists who developed the HPV vaccine. And it's a vaccine that was initially developed to fight HPV infection so that cervical cancer didn't get developed. But fortuitously, it also affects HPV in terms of oropharyngeal cancer. There's 3 different vaccines made by 2 different manufacturers. All of them are FDA approved, and all of them are approved for boys and girls at the age of about 10 or 11 to start receiving. Unfortunately, even though the vaccine has been approved since 2006 in females and 2011 for males, the vaccination rate for HPV as of 2 years ago was less than 50%. So if you think of other vaccines, and there are challenges across the country, and it tends to get notoriety, is the anti-vaccination kind of contingency has caused vaccination rates for Tdap and MMR and hepatitis B to decrease to not be 100%, but there's still about 90% vaccination of kids are getting these vaccinations. However, for HPV, only less than 50% of kids are getting their recommended vaccine for HPV. And so there's definite room for improvement, and it's not just the sexually transmitted infection that we're trying to prevent with this vaccine, it's the cancer that develops 10 to 30 years later. And so it really is a critical vaccine. California is a little bit better than other states, but again, we're 50 to 59% vaccination. It's really not enough to prevent this cancer from occurring. We did a study last year looking, we asked pediatricians across the state of California how often they recommend the HPV vaccine to their patients, just to try and understand why more kids are not getting vaccinated. And 89% of pediatricians in the state of California said they always recommend the vaccine to their patients. However, when we ask what percentage of eligible patients have completed the series, only 20% said more than 75% of them complete the series. So a lot of patients are not completing the series, even though most pediatricians are recommending it to their patients. So then we asked, what are the barriers to vaccination? One barrier was that parents are unconvinced of the benefit. Parents are opposed for safety reasons, and parents are opposed for ethical or spiritual reasons. So I think there's a lot of education that needs to occur. I think the old adage is, oh, if you vaccinate for a sexually transmitted infection, somehow you're promoting sexual activity. It really is not, it doesn't have to be thought of like that. It's a shot just like the MMR and the Tdap and the hepatitis B shot are. And not only does it prevent a sexually transmitted infection, but it can actually prevent a cancer, which is the fastest growing head and neck cancer today. Lastly, we asked pediatricians, is there a need for education? Would further education on the link between HPV and head and neck cancer make you more comfortable discussing the vaccination with your patients? And 72% of them said yes. So we as head and neck surgeons and as radiation oncologists that treat head and neck cancer have an important role in educating primary physicians at an early age for children to hopefully stem the tide of cancer that's become an epidemic in this country. And I think it's important for us to keep that in mind, especially at academic medical centers, which is one of the reasons why we're out here today talking to you guys. So in conclusion, cancer of the tonsils and the back of the tongue is an epidemic. HPV-associated cancer is rising very rapidly here in the United States. It's affecting younger and healthier people, but it is treatable. And ultimately, what I'd like is, by the end of my career, for the rates of, I think it's too late for the disease to be eradicated, but I'd like for the rates to be going down because of vaccination today. So those are really the most important things we can do to prevent this disease. Thank you. Like I said, I went into head and neck cancer because I like the relationship between patients and the relationships you develop. And I'm fortunate to work with two partners also who do exactly what I do, Dr. William Armstrong and Dr. Yara Hadar, who are good people and really value the relationships that physicians have with their patients. Thank you.
Thank you, Dr. Chen, and thank you, Dr. Tjoa. We have a few questions here. The first one, and I had asked about this earlier, it's tonsils. Having your tonsils removed, does that lower your risk of developing the cancer? I'm of the generation when they always took out your tonsils, and mine were removed twice. So I remember that very specifically. So is it better to have your tonsils removed?
That's a great question. It used to be the case, like you said, that everyone got their tonsils out when they were kids. And unfortunately, like you said, sometimes you take them out and they regrow. And so we find that even if you've had your tonsils out, there still is tonsil tissue back there, and it doesn't necessarily get rid of the risk of developing one of these.
Okay. And also, this question is about controversy for girls with the HPV vaccine. That it is painful, plus it has side effects. I wonder too if there's a social stigma attached to having that vaccination. Is that why you have only half of the people for whom it's recommended deciding to go forward with it?
Yeah, I can go ahead and take a stab at that. So that's a really great question. So regarding the logistics of the vaccination, I don't give it. I don't know enough about the pain, but I imagine it's just like any other vaccination process. I think we've all gotten the flu vaccine recently, but there's an injection, there's a needle, and that's certainly not comfortable. Oftentimes, our arm hurts, our shoulder muscle hurts, and so it's a pain. So the latter question regarding the social stigma, and that's a really interesting question. So I moved to UC Irvine from the University of Kansas, and Kansas in the Midwest is in the middle of the Bible Belt, and we actually had the lowest rates of HPV vaccination in the whole country. And it wasn't something that we were proud of, and as a clinician, we spent quite a bit of time trying to do outreach in the community and really try to change that stigma. And a lot of that stigma had to do with religious reasons as well as social stigma. A lot of folks felt that, well, if you're vaccinating your young girls at an early age, are you perhaps giving them a green light to be promiscuous or to engage in sexual activity? And so obviously that's a very simplistic way of looking at it, and I think those sort of decisions are much more complex. But I could say firsthand that in certain parts of the country, especially where I came from, those social stigmas in terms of trying to get folks vaccinated were very, very real. So it's not something that we can underestimate. And I think it's up to us as a community and as clinicians to really educate and take charge of these public health issues. I think analogously, in present times, if you turn on the news today, there's news of a coronavirus vaccine out, with Moderna and then Pfizer. And I know people firsthand that are telling me I'm never going to get the coronavirus vaccine because I'm afraid of X, Y, and Z. So I think the vaccinations as a whole is somewhat of a touchy subject sometimes. And so it's one that we need to address altogether with the facts as a medical community.
Thank you. I was also wondering, Dr. Chow, about the robots that you're using in surgery. Do you see them as competition or as complementary? How do you interact with them in the operating room?
Yeah, that's a great question. I think, the robot is just a tool. I think the surgery is a cancer surgery is a cancer surgery. What you're trying to do is get the cancer out completely with clear margins. The way we used to have to do that was pretty crazy. We'd have to go through a lot of structures to get there. All the robot is today is a tool for us to use to get that cancer out without causing all the side effects that we used to need. So, sometimes we just need a little cautery instrument in our hand and a dissector in our left hand. The robot is just a really expensive version of those two things, but it allows us to get back there without having to do these crazy things to people's faces to approach it. So the robot, I don't imagine, maybe I'm being short-sighted with my imagination, I don't imagine it's ever going to take place of surgeons. I think it's controlled by us. We're using the computer to control what the robot arms are doing. And there's a lot of training that goes into knowing where to make cuts around the tumor to get it all. And I don't know that the robot will ever be able to do that in an automated fashion. So I personally don't see it as competition. I see it as a tool.
I heard you both saying actually that the less your skills are needed, the healthier our society. Is that the case? Did I hear that correctly? Dr.
Yeah, I think both of us would agree that we'd love to be out of business someday.
Yeah.
Head and neck cancers, like a lot of cancers, can be prevented. Certainly there's an element of randomness that's involved with anything, but a lot of these cancers are lifestyle driven, and nowadays, as you mentioned, with vaccinations, there's no reason why we shouldn't see a declining incidence, and hopefully one day an elimination of cancer. And hopefully both of us will be retired by then, living on a beach somewhere and enjoying margaritas. But we love to be out of work.
Okay.
Yeah, agreed.
All right, here's one last question. If I had HPV, a cancer-causing strain, and needed it removed due to developing dysplasia in my cervical area, am I more at risk for HPV cancer in my throat? So is there a relationship?
Dr. Tjoa, would you like to take that one?
Yeah, that's also a very good question. I think a couple things to keep in mind. Like Dr. Chen mentioned in his talk, almost everyone gets HPV at some point in their life. In women, it can cause cervical cancer. It's actually very rare for women to get the HPV-associated throat cancer. And so, given how prevalent cervical cancer is in women, it's unlikely that having cervical cancer increases your risk of HPV associated throat cancer. And there are some theories out there that just by having HPV infection in the cervix and having a cancer there, your body's immune system is almost primed to fight it. And that's one of the theories for why women get HPV-associated throat cancer less than men, is because they do have this immune surveillance going on that's caused by exposure in the cervix.
Yeah, and just to add on to that, like Dr. Tjoa mentioned, the virus is just so common in society, and most of us are exposed to it at one point or another. There was actually studies done looking at partners or spouses of men with HPV oral cancer and throat cancer, and seeing if perhaps those partners or spouses might be at higher risk for developing throat cancer just from cohabitating or sleeping with or kissing these folks on a regular basis. And they really showed no increased risk. Really, then that's really additional evidence that, we don't have any idea of who are the ones that actually develop these cancers in the context of all of us being exposed.
Thank you. Well, I'd like to thank both of you for being here today, Dr. Alan Chen and Dr. Tjoson Tjoa. It's been a wonderful afternoon. We appreciate what you've shared with us. And actually, I think you've given us a sense of confidence that these things are not that we can survive, that we can go forward, and that we can thrive. So thank you very much, and go forward, all of you who are here this afternoon. We have welcomed you. This will be recorded, and you can access it on the Foundation's YouTube channel. Thank you very much.
Great.
Thank you. Take care,
Thanks for
everybody.
having us.